All right, this lecture will be on the pons. We'll be following pathways from the spinal cord and medulla, and also introducing some new nuclei and a few new pathways. Let's start with the trigeminal system. We mentioned the substantia gelatinosa in the spinal cord, which is for pain and temperature. And we said that when that enters the medulla, it changes names. We call it the spinal trigeminal nucleus and tract. But it's really just pain and temperature, but now for the face. Okay, this pathway does continue up into the pons. But notice here's our trigeminal nerve. And so there are three divisions, ophthalmic, maxillary, and mandibular. But in the pons, we now have the motor contribution to the trigeminal nerve right here in blue. And adjacent to that is the principal, or sometimes called the chief, trigeminal sensory nucleus. We'll talk about the unique function that has. And then out here we have the mesencephalic nucleus, which extends up a little bit here into the midbrain as well. Okay, so we'll have all of the trigeminal system here described in this lecture. Another important relationship here when we talk about the pons is between cranial nerves 6 and 7. So here is the motor nucleus for 7, the facial motor nucleus. And this has a very unusual exit. Notice, let's just contrast it with the trigeminal as an example of virtually all cranial nerves. They just exit straight out. But the facial nerve here actually goes dorsal, wraps around the abducens nucleus, and then out. So here's the abducens nucleus. And so kind of our classic lesion in the pons will often involve 6 and 7 because they're immediately adjacent to one another. All right, so this section is kind of upper medulla transitioning into the pons. So we still have the cortical spinal tract here in this midline location. Medial lemniscus is still here along the midline. Okay, and here is our inferior cerebellar peduncle, all right, which connects the medulla with the cerebellum. So remember the spinocerebellar tracts travel through here, and we also have contribution between the vestibular nuclei, which are in this location here and over here. These also feed back and forth to the cerebellum through the inferior cerebellar peduncle. Okay, here's the cerebellar cortex here. So we talked about that in the lecture on the cerebellum. And here is the inferior Oliveri nucleus. Okay, and this also provides a pathway, a connection between the inferior olive and the cerebellum through the inferior cerebellar peduncle. Okay, and these are called climbing fibers. We mentioned that in the lecture on the cerebellum. Remember the salt and pepper appearance here? The pathway, the dark little dots here, is all lateral vestibulospinal tract. Okay, the nucleus I don't care that you know about. It's one of the vestibular nuclei, but the pathway is important clinically. Remember, this is our classic extensor pathway. And in an abnormal situation called decerebrate posturing, we have unregulated extension of the arms and legs. So it's unregulated overactivity of the lateral vestibulospinal tract. Right, so the nuclear groups here, I mentioned the inferior Oliveri nucleus here. And the nuclei here in this area, mainly in the pons, we see this, the pontine nuclei are relay nuclei for the cerebellum. So the cortico-ponto-cerebellar tract goes from the cortex to these pontine nuclei. Okay, and then once it synapses here, it actually crosses over to the middle cerebellar peduncle. I'll mention that in the next slide where we're looking at the pons. All right, back here we have the fourth ventricle and some choroid plexus. Remember that's present in the fourth, third, and mainly lateral ventricles. All right, and then here we have the basilar artery sort of line here on the upper medulla and throughout the length of the pons. Now we have 3 cranial nerves here in this section. 2 of them are exiting here at this cerebellopontine angle. So this is 7 and 8. Okay, remember that an acoustic schwannoma is a classic tumor that grows here. It tends to involve 8 early, so patients have hearing loss, but then they can have some facial nerve involvement as well. And sometimes if it compresses the cerebellum, they can have some ataxia in addition. All right, and here we have cranial nerve 6, the abducens nerve. All right, so this nerve comes out along the midline. We can see a little bit over here, right at the junction between the medulla and the pons. Okay, so here are all of the labeled structures here. Right, so again, the lateral vestibulo-spinal tract is in this area. There are some things I labeled here that you don't need to be able to identify, but it makes sense that the 8th nerve comes in here, and so these are cochlear nuclei back here for hearing. Here we can see the cochlear nuclei on this side, but I won't ask you to identify those. We still have the spinal trigeminal nucleus and tract for pain and temperature for the face. And also, it is important that you just remember the nucleus ambiguus is in the lateral medulla. Okay, remember that's part of our lateral medullary syndrome. And so the dysphagia, dysarthria, and hiccups are all from a lesion there. But hard to know exactly where it is. And so you don't need to be able to identify it, just know where it's located. So our rule of thumb for any brainstem syndrome is that we have crossed findings. All right, we saw that actually with both lateral and medial medullary syndrome. And crossed findings mean we have an ipsilateral cranial nerve deficit, a contralateral motor or sensory deficit. So for medial medullary syndrome, it was an ipsilateral hypoglossal nucleus lesion, but the involvement of the cortical spinal tract and medial lemniscus gave a contralateral motor and sensory symptom. In lateral medullary syndrome, everything was ipsilateral, but our kind of classic crossed finding that we talk about is you have ipsilateral spinal trigeminal nucleus and tract involvement. That gives you ipsilateral loss of pain and temperature on the face, but the spinothalamic tract involvement gives you contralateral numbness and loss of pain and temperature in the opposite arm and leg. All right, now when we're in the Pons, we look for the same thing. Ipsilateral cranial nerve deficits, contralateral motor or sensory deficits, and we will talk about Millard Gubler syndrome as our one example of this with a stroke in the Pons. But one thing that's kind of unique about the Pons is a lot of reticular activating system is in the Pons. And so when you destroy that, you very easily then lead to coma. And so a pontine stroke of a significant size will frequently result in coma. Okay, and then in the next lecture, we'll talk about a crossed syndrome in the midbrain. But just remember, that's always our rule of thumb with a brainstem lesion. Ipsilateral cranial nerve, contralateral, motor, or sensory. All right, so now we're up in the Pons. And so, but, don't panic here when we look at this. Still always think, okay, what is midline? And so this is still then the cortical spinal tract that's in the midline with the medial lemniscus still in the midline. Okay, but now we have this huge pathway out here. And so this is the middle cerebellar peduncle. Middle cerebellar peduncle is by far the largest connection between the brainstem and the cerebellum. And so this is 100% one pathway, the cortico-pontocerebellar tract. So this is information going into the cerebellum, and this is the motor program. So that the cerebellum can serve as its role of a comparator, it needs to know what the intended movement is. And so this is information going through the middle cerebellar peduncle. Now, a new pathway here. This cut is a little asymmetrical here from the de-Armand atlas. And so we're looking at one inferior olivary nucleus. Okay, and you can kind of see there's a pathway coming out of this. Over here, it's the same pathway, but we don't see the inferior olive on this side. And so this pathway is called the central tegmental tract. And this pathway connects the inferior olivary nucleus in the medulla, primarily, with the red nucleus in the midbrain. Okay, and so a lesion of the central tegmental tract gives a very unusual clinical syndrome called palatal myoclonus. Okay, and I have a video linked to this in Canvas that you can look at. And it's very unusual. These patients just have a continuous rhythmic up and down motion of their palate. And that's very annoying for patients. Often they have a sound of clicking along with that palate involuntary movement. And so if you see a patient with that, where's the lesion? Well, very specifically, the lesion is the central tegmental tract. More generally, you would say the lesion is in the pons, usually. And so it would be important in that patient to get an MRI scan and look and see, what is involving the central tegmental tract. This is a very myelinated pathway, so it certainly could be involved in multiple sclerosis or stroke or anything structural. But palatal myoclonus you want to associate with a lesion of the central tegmental tract. Now, in terms of the nuclei, we have some very large nuclear groups back here, 4 of them. Okay, this one out here kind of looks like the inferior olive, but it's in the wrong location. This is the dentate gyrus. Okay, and then we have the umbiliform, and then the globose, and finally the fastigial. So all 4 of these are part of what's called the deep cerebellar nuclei. And in the lecture on the cerebellum, we'll talk about how anything going in or out, virtually anything going in or out of the cerebellum has to relay through these deep cerebellar nuclei. So associate these with the cerebellum. Okay, another part of the cerebellum is seen here. This is the nodulus. So the flocculonodular lobe we'll discuss has a very important role in terms of eye movements and the vestibular system. And so the nodulus is right here in the midline projecting into the 4th ventricle, which is right here. And again, we still see some choroid plexus here. Now notice we have here just millions and millions of neurons. The reticular activating system always kind of looks like a misty cloud here. So this is the reticular activating system. And so again, this is very important among several other functions of activating the cerebral cortex of the brain. So again, that's why with a stroke of the pons, if enough of the reticular activating system is affected, then the patient is in a coma. All right, so palatal myoclonus, I mentioned, with a lesion of the central tegmental tract. And here are all of the labeled structures. Again, a few things here, only the ones that have an asterisk in the handout you're responsible for. Now, as we move up, very clearly here we're in the pons, kind of a classic appearance of the pons with the cortical spinal tract, pontine nuclei. Okay, so again, when you think of the pontine nuclei, it's the cortico-pontocerebellar tract. So it's the synapses on the pons and then crosses over here in the middle cerebellar peduncle. But this one is really important, this section, because we can see 2 new nuclei here in these locations. This is the facial nerve nucleus, and this is the abducens nucleus. All right, so remember the very unique thing here, which is that the facial nerve does not just exit straight out like this. It actually travels around this way. This dark area right here is called the genu of the facial nerve, or the bend. And so it travels around, it wraps around the abducens nucleus, and then this is the facial nerve right here that we can see exiting. Okay, so 6 and 7 are very close together here in the pons. You could have a small lesion right here, get a ipsilateral 6th and 7th cranial neuropathy. Now remember, when we look at the external surface of the brain, 6 and 7 are far apart, right? The 6th nerve exits, we saw it exiting about here, lower down in the midline, whereas cranial nerve 7 exits way out here. So if you have a patient with a 6th and a 7th cranial neuropathy, the lesion is here. It's in the pons. Okay, so that is just a really important relationship. Now, a pathway that we were used to seeing standing up here above the cortical spinal tract, now we see it's lying flat. This is the medial lemniscus. Okay, so again, this is vibration, proprioception, and this pathway lies flat, and then we will follow it as we move up. It moves out laterally, kind of up like this. Okay, but this kind of has an L shape here. The bottom of the L is the medial lemniscus. Okay, this part here is the central tegmental tract. Remember, this is the pathway that connects the red nucleus and the inferior olivary nucleus. So that forms the L right here. Okay, I already mentioned the middle cerebellar peduncle, and then here we're seeing the superior cerebellar peduncle. Okay, so this mainly connects the cerebellum with the midbrain. Remember, most of this is outgoing information from the cerebellar cortex back to the motor cortex of the brain. Okay, I pointed out the pontine nuclei, the seventh nerve, and I should say when we talk about the abducens nucleus, that this is often called the sixth nerve PPRF complex. So kind of lump the PPRF in along with this. Remember, the PPRF is the horizontal gaze center, paramedian pontine reticular formation of the pons. Coordinates horizontal eye movements. Okay, again, all of the misty, millions of nuclei here. This is all reticular activating system. And we can still see the fourth ventricle. Actually, I don't see any choroid plexus in here, even though I've got this listed on the slide. Okay, and here is everything labeled. Again, 7 wrapping around 6. The L, the base of it is the medial lemniscus, and then this portion is the central tegmental tract. Now, the superior olivary nucleus, I didn't have this labeled as something you should be able to identify, but we will talk about the function of that here in just a minute. All right, so here is one pontine syndrome. I really don't care that you know it's called Millard Gubler, but I would like you to be able to localize it. And so our lesion in Millard Gubler syndrome involves 6 and 7. So what blood vessel involved? Well, the basilar artery supplies the pons. So this is going to be a stroke of often a penetrating branch off of the basilar artery. All right, so our patient will have an ipsilateral 6th and 7th nerve palsy. Remember, cranial nerves don't cross, except for 4, and that really isn't important clinically. And so the patient here with the lesion on the left is going to have a left 6th and 7th nerve palsy. But if you affect the cortical spinal tract, since this hasn't crossed yet, the patient will have a right hemiplegia or a contralateral hemiplegia. All right, so if the lesion's on the left here, as we look at the patient, here they have a left 6th nerve palsy, so the lateral rectus isn't working, the medial rectus is stronger and it pulls the eye in. Okay, and notice we've got left facial weakness. We don't have any wrinkling of frontalis muscle here on the left. We've got a left facial droop. It's a lower motor neuron 7th nerve palsy. It affects the forehead and the lower face. Okay, and a contralateral hemiplegia. Okay, so again, any brainstem lesion, ipsilateral cranial nerve deficits, and in this case, a contralateral motor deficit. Now, could more be affected? Of course. So if we had a big stroke affecting half the pons, it would affect sensory pathways and other things could be present as well. But these are the essential features that I think I'd like you to know about the Millard Gubler syndrome. And there are, 100 variations on the theme in terms of other sensory pathways or things that could be affected here. But I think I'm happy if you know these 3 anatomical areas that would be affected in this syndrome. Now, this is a very busy slide, but yet I think really quite instructive. A lot of this we've already talked about, but now kind of puts a little more details on it. So first, let's just appreciate here that our semicircular canals, when you turn your head, it stimulates flow of endolymph in the semicircular canals. And this information then electrically is carried into the brainstem via the 8th nerve. Okay, and as it relates to turning your head side to side, the medial vestibular nucleus receives that information. So notice in this case, patients turning their head to the left, and so the eyes in that case want to go to the right. All right, and so let's see how that happens. So you turn your head to the left, the eyes go to the right. So information goes into a vestibular nuclei and then crosses over to our PPRF6 nerve complex. Okay, and so this needs to turn the eyes to the right for this vestibular-ocular reflex to be intact. And so the sixth nerve then talks here to the right eye, to the lateral rectus, which is going to pull the right eye to the right. Okay, but for this to coordinate with the left eye medial rectus, this is where we need our medial longitudinal fasciculus here. And the medial longitudinal fasciculus, you want to associate that with connecting PPRF6 with the opposite medial rectus muscle. All right, and so now both our medial and lateral rectus muscles are working together. Okay, and so that's our vestibulo-ocular reflex. Next year, we'll go back and talk about cold caloric testing and how that is involved here in this as well. Now, we also said that if you have a lesion of the MLF, either here's the medial longitudinal fasciculus over here, we said that is going to affect one muscle, and that is the medial rectus. Right? So if we have an MLF lesion, we call that an internuclear ophthalmoplegia because it's a pathway that is between nuclei. Okay, it's between PPRF6 and the medial rectus. And so the patient will have weakness with the medial rectus muscle. And remember that they'll have some nystagmus in the normal eye. We showed some videos of that. And so classically, you associate an INO with demyelinating disease, multiple sclerosis. Now, here's something, we'll add on a little bit here to something we talked about before. I told you that if you have a stroke here in the pons and you affect PPRF6, and that we can have eye deviation in that situation. So to imagine what will happen, if we destroy the right PPRF6, just ask yourself, what does this do normally? And normally, we said it drives the eyes to the right. Okay, the lateral rectus, and then via the MLF, the opposite medial rectus. And so if you destroy an area that wants to move the eyes to the right, sometimes the eyes then get driven to the left. Okay, and remember I said that's part of our gaze palsy, where the patient now has eyes that look at the hemiplegia. But sometimes with a lesion here, we don't get eye deviation. The patient just can't look to the right. Okay, we would call that a right horizontal gaze palsy. Okay, so if you have a lesion right here, the patient can't look to the right. Now, if the lesion's a bit larger, now here's the bit of new information, it can extend out and it can involve this ipsilateral MLF. Okay, so now we are losing the pathway going to the opposite MLF, but we've also destroyed the ipsilateral MLF. And so now when this patient tries to look from side to side, they can't look to the right. Okay, and when they look to the left, now they've lost the MLF on both sides. Okay, so really the only muscle that is intact is the contralateral sixth nerve to the lateral rectus in this eye. And this is called the 1.5 syndrome. And so here's a video, of a patient with a 1.5 syndrome.
This patient presented with double vision. She cannot look fully to the right, horizontal gaze palsy. Looking left, a right internuclear ophthalmoplegia, abducting nystagmus of the left eye, paresis of the right medial rectus. Good convergence.
Okay, so eye movements are difficult. You need to look at it several times. So this patient has a lesion of the right 6 PPRF complex, so she can't look to the right. Okay, when she tries to look to the left, now the lesion affects the MLF on the right as well. So this eye can't look to the nose. So the only thing that is working is the 6th nerve here on the left side. Let's just watch it one more time.
This patient presented with double vision. She cannot look fully to the right, horizontal gaze palsy. Looking left, a right internuclear ophthalmoplegia, abducting nystagmus of the left eye, paresis of the right medial rectus. Good convergence, full up gaze with upbeat nystagmus.
Okay, so I don't care that you know about upbeat nystagmus, but there are a couple of other helpful things in that video. First of all, notice that when patients have an MLF lesion, it does affect their ability to look from side to side, but not convergence. Okay, so we have a convergence nucleus here that kind of yokes the medial rectus muscles together. So convergence is preserved when we have either an MLF lesion or a 1.5 syndrome. So we don't have convergence insufficiency. The other thing worthwhile pointing out is that she could look up and down pretty well. And vertical eye movements are a function of the midbrain. All right, so with a patient that has a lesion here, their problem is looking side to side, horizontal eye movements, not so much vertical eye movements. Now, one other thing about the sixth nerve. Lots of things can affect the sixth nerve, but the sixth nerve is classically involved when we have increased intracranial pressure. And that can be from any number of things. A mass lesion in the brain, like a tumor or a hemorrhage or hydrocephalus. And so increased intracranial pressure will often cause traction on the brainstem that will damage both sixth nerves. And so we get a bilateral sixth nerve palsy with increased intracranial pressure. So notice as this patient looks straight ahead in primary gaze, the right eye gets pulled in, which should suggest to you that the patient may have a sixth nerve palsy in this eye. And this is obvious when the patient tries to look to the right. The left eye looks to the nose well, but the right eye cannot abduct. So we have a right sixth nerve palsy. But notice also when the patient looks to the left, here she's trying to look up at something up here. So the left eye, moves in well, but the right eye looks to the nose, but we don't have normal abduction in the left eye. Likewise, when she tries to look down at a target here, the right eye is on target, but the left eye does not abduct normally. So it's more subtle here on the left, but we actually have a bilateral sixth nerve palsy. And when you see a bilateral sixth nerve palsy, that's concerning. You always need to get a brain scan, CT, MRI scan, and find out why the patient has increased intracranial pressure. All right, so this is a very significant finding and always warrants an investigation. In the second year course, we'll talk about idiopathic intracranial hypertension and as a cause sometimes for this. One other pontine syndrome is called Lockedin syndrome. And so this is a devastating stroke of the pons. You can see the white area here affects the whole ventral portion of the pons. Now this area back here is relatively preserved, and this is where most of your reticular activating system is. And so these patients knock out all of the descending upper motor neuron pathways, and so they're paralyzed. It also affects the cortical bulbar tract, which we'll talk about here in a little bit. That's the upper motor neuron pathway that activates your cranial nerve nuclei, like for talking and swallowing. So these patients are unable to speak, they're unable to move, but they're awake. All right, so it's a very sad condition. Typically, these patients don't survive very long. The very unique thing about Lockedin syndrome, because the lesion is in the pons, not the midbrain, and I just said that the midbrain is important for vertical eye movements, these patients can look up and down, and that's how you communicate with them. Right? So you ask the patient, please look up 3 times, or something like that. And so their vertical eye movements are relatively normal. All right, so that is Lockedin syndrome, and again, very high mortality with that. Okay, now we're still in the pons here, and again, here's the large portion of the pons here, what we call the basis pontis. So we can still see the cortical spinal tract here. And now we'll start talking about up here a distinctive pathway, and this is the medial longitudinal fasciculus. And it makes sense that we find that here because we just saw cranial nerve 6 PPRF, and remember the MLF provides communication between 6 PPRF and the part of the third nucleus that supplies the medial rectus muscle. So a lesion here would give you an internuclear ophthalmoplegia. Okay, we have out here still the middle cerebellar peduncle, the superior cerebellar peduncle. Okay, but the unique thing here that we see is new parts of the trigeminal system. All right, so the little finger-like projections here, this is the actual trigeminal nerve. Okay, the nucleus right here is the motor nucleus of the trigeminal nerve. So remember that supplies your medial lateral pterygoids, masseters, temporalis muscle. The nucleus here that contributes to the trigeminal nerve is the principal or chief sensory trigeminal nucleus. Okay, and we'll describe what that does here in just a minute. And then in this area right here, we have what's called the mesencephalic trigeminal nucleus. So we kind of got 3 new parts of the trigeminal system right in this location. Okay, we still have the 4th ventricle here. All right, so again, we've got the trigeminal nerve, the motor part of the trigeminal nerve, the principal sensory nucleus, and the mesencephalic kind of out here in this location. Now, I didn't label it, but the locus ceruleus is in this location right here. Remember, the locus ceruleus produces norepinephrine, and so we find it kind of here in the wall of the 4th ventricle in the pons. Okay, so the motor trigeminal nucleus supplies these muscles here, very important for moving your jaw, chewing, and so a lesion here of the motor trigeminal nucleus or the trigeminal nerve will have a weakness of chewing and some atrophy in those muscles, particularly the temporalis and masseter muscles. You can appreciate atrophy there with the lesion. And just like with the lesion of the hypoglossal nerve, remember the tongue deviates toward the side of the lesion. We have the same thing if we have a trigeminal nerve lesion, where the jaw actually deviates toward the side of the lesion. Now, the principal sensory trigeminal nucleus is tactile sensation for the face. All right, and so not pain and temperature, but vibration and light touch would be sensory modalities that are provided by the principal sensory trigeminal nucleus. And really important that you link the principal sensory trigeminal nucleus with the corneal reflex. All right, so remember the ophthalmic division supplies the cornea. So when you touch the cornea, this information goes in to the principal or chief sensory trigeminal nucleus, which then stimulates bilateral facial nerve nuclei, which goes out to close both eyes via the orbicularis oculi. Remember, 7 closes the eyes. All right, so in maybe a better drawing here, again, touching the cornea activates principal or chief sensory trigeminal nucleus, and then bilateral facial nerve nuclei. So if we have a lesion of the trigeminal nerve, you touch the cornea, nothing's going to happen. We don't get either direct or a consensual eye closure. Whereas if we have a lesion here, let's say Bell's palsy of the facial nerve, now if you touch that cornea, the ipsilateral eye isn't going to close very well, so no direct closure, but we'll get good closure here of the opposite eye, so the consensual reflex is intact. So we can figure some things out by doing the corneal reflex. Remember, we mainly do this in a comatose patient. And so I would say the biggest utility of the corneal reflex is if you touch the eye in a comatose patient, touch the cornea gently with a wisp of cotton, and both eyes close, all of this circuitry is in the pons. So what it tells you is that the pons is working pretty well, and probably the reason for the coma is not something going on in the pons. Now, the mesencephalic trigeminal nucleus is really a displaced ganglia, like the dorsal root ganglia, but it gets shoved into the central nervous system. All right, and so the mesencephalic nucleus, you want to associate that with proprioceptive information, and so information from muscle spindles about where your jaw is in space go back to the mesencephalic trigeminal nucleus. And then, not surprisingly, this is activated by the jaw jerk reflex. So you tap the jaw, it's going to activate muscle spindles, and therefore the mesencephalic trigeminal nucleus. Okay, so here's the input. And so you need this when you're chewing or talking, right? You need to know where your jaw is in space. So this goes all the way up here to the mesencephalic nucleus, which extends here from the pons all the way up into the midbrain. And there's a direct connection then between the mesencephalic nucleus and the motor nucleus of the trigeminal nerve. So when you tap on the jaw, then the reflex is into the mesencephalic, and then it activates the motor trigeminal nucleus, and your jaw snaps back up. So that's why we have mesencephalic and the motor trigeminal nucleus right next to each other. All right, the other pathway, I don't have it labeled so that you need to identify it, but I really want you just to know the function here. The superior Oliveri nucleus is very important for auditory information. Okay, don't get it confused with the inferior Oliveri nucleus. That's an important relay nucleus for the cerebellum. But the superior Oliveri nucleus is important for sound localization. So notice we have one here and over here, and sound from the right and left ear hits these nuclei at slightly different times, and so it gives you a good depth of localizing sound, really. And actually, these nuclei are capable of focusing in on sound. So if you want to try to hear something at a certain location, or you may have had an experience at a party or something, you're talking with someone, but you really want to hear what someone else is saying, you can kind of fine-tune what you're going to listen to. That would be a function of the superior Oliveri nucleus. All right, so just to kind of put together auditory pathways, of course, this originates in the cochlea, and we've described the eighth nerve entering into the medulla primarily, and then we have cochlear nuclei in the dorsum of the medulla. Superior Oliveri nucleus is for sound localization, so this information is heading up to Heschel's gyrus. Remember, that's primary auditory cortex, but there are several little synapses along the way. So one is in the superior Oliveri nucleus, and the pathway then that extends through the brainstem, we'll see on the next slide, is the lateral lemniscus. Lemniscus is just a pathway. And so medial lemniscus, remember that's vibration proprioception. Lateral lemniscus is auditory information. Okay, we'll see that the lateral lemniscus synapse is on the inferior colliculus. Okay, and we've already discussed that's an auditory nucleus. And then finally, the medial geniculate of thalamus, and then to Heschel's gyrus. Okay, so medial geniculate, remember anything going to the brain needs to talk to a nucleus of the thalamus except for smell, and so the medial geniculate is for auditory. All right, so in this section of the pons, the cortical spinal tract is kind of scattered throughout, but it's still going to be mainly in a midline location. But here we have kind of three pathways here. And so remember the medial lemniscus, we saw it lying down. And now this is the spinothalamic tract. Now I've stopped pointing out the spinothalamic tract through the medulla and pons because it's hard to identify. But here it's very large and it's right adjacent to the medial lemniscus. So remember medial and lateral medullary syndrome, we had the medial lemniscus involved in medial medullary syndrome, the spinothalamic tract in lateral medullary syndrome. They were far apart. But as we move up through the brainstem, they move close together. And they move close together because they are headed to the same nucleus of the thalamus. They're both going to VPL of the thalamus. All right, so all sensation from the contralateral arm and leg for vibration proprioception, pain and temperature, it's all kind of traveling right here in this location. Now this pathway is the lateral lemniscus. Okay, so again, this is auditory information from the cochlear nuclei, superior olivary nucleus, and this is going up to the inferior colliculus. Okay, the MLF is still, again, always right in this very midline location. These are all pontine nuclei again. And so now we can kind of imagine here the cortical pontocerebellar tract is kind of entering into synapse on all of these pontine nuclei. All right, up here, most of this is going to be the superior cerebellar peduncle. Remember the outflow from the cerebellum that is going up to the motor cortex. And there's a nerve back here. And so just remember there's only one nerve that exits the dorsum of the brainstem, and that is the trochlear nerve. This has a very long course. It's very easily damaged by head trauma. We can easily get shearing of this nerve here. Okay, again, the misty cloud of neurons here is the reticular activating system in this whole area. All right, and now we're above the fourth ventricle, and so what we're looking at here is the cerebral aqueduct. Okay, with, notice, lots and lots of neurons around it, and this is called the periaqueductal gray. And the periaqueductal gray is just loaded with opioid receptors. And so later on we will discuss pain and pain pathways, and as part of a descending pain pathways, the periaqueductal gray is very important for that. Okay, so again, cerebral aqueduct, periaqueductal gray around it, and medial lemniscus, spinal thalamic tract, lateral lemniscus here. And it would be really hard to separate here. I labeled cortical spinal tract here and over here, and I put the cortical pontocerebellar tract here, but there's going to be some cortical spinal tract, kind of mixed in here. But I mainly just wanted to remind you that the cortical pontocerebellar tract is going to synapse on all of these pontine nuclei here. All right, so that's our last slide on the pons here, and we'll finish up on the midbrain next time.